laparoscopy is the panacea for all abdominal surgeries. For those who are not familiar with the geography, especially those who are coming to India from overseas, I am coming from Sri Lanka, island in the Indian Ocean, which has a lot of beautiful tourist attractions, and the total population of the country is about 23 million, very much less compared to India. This is where I work since 2006. It is directly linked. This is Colombo South Teaching Hospital. This is directly linked to the Faculty of Medical Sciences of the University of Sri Jayawardena. And I'm sure there are many members in this audience who have visited this hospital, and I can still remember as a surgical trainee in 2006, I was assisting Dr. Palani Velu to perform first laparoscopic cardiomyotomy in this hospital. Since then, we have come far away, and now we are a tertiary referral center for advanced laparoscopic surgeries. Not only that, we perform advanced therapeutic endoscopies and ERCPs. In contrast to India, most of the surgeons do endoscopic as well as ERCP procedures. Prestigious, well-known figures from India, Hyderabad, Dr. Nageshwar Reddy has also visited several times to this hospital to conduct several workshops. The aim of this oration is to tell you whether the laparoscopy is a panacea for all abdominal surgeries. In achieving this objective, I would also discuss briefly how the laparoscopy evolved over the past. What are the advantages of laparoscopy as well as disadvantages? Are there any hazards of laparoscopy to the surgeon, to the patient, and also to the environment? And most importantly, what are the factors one should consider in deciding the best surgical approach for a particular patient? And is it possible for us to conclude that laparoscopy is a panacea for all abdominal surgeries? When we look at the history of laparoscopy, as you all know, in 1805, Philip Bossi developed an outward system of candles and mirrors to examine canine bladders. Almost a century later, a Swedish surgeon, Hans Jacobs, is credited for coining the term laparoscopy into our vocabulary. Laparoscopic concept crossed the borders between diagnostic medicine and therapeutic surgery thanks to this pioneering surgeon and gynecologist, Professor Ket Sem, whose family owned a manufacturing company. And according to his ideas, several hand instruments that we use today were developed in this institute. Then later, in 1985, I would call the medieval history of laparoscopy. Professor Eric Mu performed first laparoscopic cholecystectomy. Although, as you all know, Philip Morey, the gynecologist, has been frequently cited as having performed the first procedure. Then gradually, laparoscopy became very popular, with lots of obstacles erupted in places where there were surgeons who were very reluctant to take up this new technique. As we all know, there are tremendous developments in technology, especially fiber optics, over the last few decades. This had huge impact on laparoscopy as well as endoscopic surgery, with a considerable cost involved in establishing the facility in our part of the world. Despite that, we should be very proud that we have produced best surgeons in laparoscopy in this region of the world. With regard to the technology, from the days of development of telescopes with rod lenses, we have come a long way. And now we have flexitip telescopes with 3D and 4K technology with IR imaging. For example, it has been shown that with IR imaging, we can now predict the chance of leaking bowel anastomosis. Not only that, not only the fiber optics, hand instruments have also been developed trying to match the movement of the human hand. Also, methods of access have been developed. from Beres needle and open Hassel technique to usage of optical ports. In addition, the multiple ports of access, we have now gel ports and SILS ports. As you know, it is a different terminology we use now. Laparoscopy is also called minimal invasive surgery. But we know that if the surgeon is not well trained, that can be maximally invasive. Therefore, I think popular terminology is minimal access surgery, which includes laparoscopy as well as endoluminal procedures, nodes and robotic surgery, which I am not going to deal in detail during this talk. However, I do not think it is justifiable to use the term minimal access surgery for laparoscopy. As we all know, it is not minimal access, but we have maximum access when we do laparoscopy. We can have very good access with magnified view to difficult areas of access, like difficult male pelvis in ultra-low anterior sections, for example. Therefore, Chairman Sir, I would call it small incision surgery, not minimal access surgery. It is a maximum access surgery through limited incisions. Good old days, people said, big surgeons make big incisions, but now we know better surgeons make small incisions. And I'm not surprised in future, people will also say best surgeons make no incisions during their surgeries. Before going into the core content of my talk, let's see why we do laparoscopic surgery. We perform laparoscopy because we know there are certain definite advantages to our patients. But some would argue that it is not much of a difference in certain diseases when we do laparoscopy or surgeons with gifted hands also perform major complex procedures laparoscopically as well. But can we recommend laparoscopy to all abdominal surgeries? Mr. Chairman, that is our question in hand. Before making this decision, let us see what are the advantages of laparoscopic surgery. There are advantages to the patient, advantages to the surgeon, as well as advantages to the healthcare institute. Less pain, fast recovery, therefore early return to normal life are advantages to the patient. Not only that, we know with laparoscopy, long-term adhesions are very much less, and adhesion-related complications are going to be less. Because of less lengthy incisions, the chances of surgical site infections are less. Therefore, chances of incisional hernia rates are less. How about the surgeon? For the surgeon, the laparoscopic procedure is ergonomically comfortable. Surgeon does not have to struggle with assistance for retractions. Best examples are deep pelvic dissections, adrenal surgery and bariatric surgery, where we use gravity as our main force of retraction. A lot of training opportunities are also available to the surgeon compared to open surgery. Number of learning material available are much more when we compare to open surgery. When you are more experienced, more patients will come to you. Therefore, it's financially more lucrative to the surgeon. What about the healthcare institute? Even though the initial investment is high, in long term, more profitable to the hospital because of the less hospital stay, the more patients will turn over, and also patients will pay more to the hospital because of the fast recovery, because of less pain and less surgical scars. However, as we all aware, there are many disadvantages of laparoscopic surgery. When we know high initial cost, complications associated with laparoscopy at entry, during surgery and during recovery. These are all disadvantages. I'm not going to deal in detail about these things. However, Mr. Chairman, now the question comes whether it's worth doing laparoscopy when long-term outcomes are the same. This Cochrane review shows that there is no difference in mortality, complications, and operative time between laparoscopic versus open cholecystectomies. However, we know that laparoscopic cholecystectomy has a higher incidence of common bile duct injuries. But I am sure with the training, more and more young energetic surgeons will have more experience on this area and is going to be safe with open surgery. When colorectal surgeries are concerned, it is also the same. There is no difference, according to this trial, in disease-free survival, whether one do open or laparoscopic colonic resections. Now, Chairman sir, I will come back to the same question. Is laparoscopy panacea for all abdominal surgeries? Is it safe to do, or is it practical to do laparoscopy all the time? I will try to answer this question with published data at our hand. This review was published in British Journal of Surgery, analyzing bowel injuries as a complication of laparoscopy. It has shown about 0.2 to 0.3% bowel damage during laparoscopy. Out of that, about 0.22% are perforations and about 0.13% are partial injuries. More injuries has occurred to small bowel, and trocars and Weller's needles are the culprits of bowel injury, while about 25% of the injuries are due to energy devices. More importantly, I want you to understand that out of all the injuries, about 68.9 patients had associated adhesions or laparotomies prior to the index laparoscopic procedure. It is also associated with 3.6% of mortality. This paper came from British Journal of Obstetrics and Gynecology, analyzing more than 25,000 gynae laparoscopic procedures. They have recorded about 0.57% overall complication rates. Out of that, 57% caused at the entry, and overall 58% needed laparotomy. When there is vascular injury, the necessity for laparotomy went up to 90%. Let's see intraoperative complications during laparoscopic colorectal resections. What is the impact of the learning curve to the outcome? This was published in the Disease of the Colon and the Rectum in 2001. Total number of 461 patients were analyzed. 90% of them were operated during the learning curve among 3 surgeons. There were no difference with reference to the demography, the disease pattern, and the complexity of surgery among 2 groups. It was reported declining overall intraoperative complications rates from 9 to 7%. Although it was not statistically significant, I am sure I would say that as far as the patient safety is concerned, it is quite significant. It has also shown declining conversion rates from 13.5 to 9.7%. It was demonstrated that learning curve for the right side resections were about 55 cases and the left side was about 62. In addition, it was shown that readmission rate and post-operative complication remained unchanged throughout the series and was not dependent on operative experience. However, ladies and gentlemen, Mr. Chairman, these are statistical analysis. I am in the opinion that when it